for those of you who don't know me, which is probably most of you, I'm Laurie. I'm one of the ST6s in anaesthetics and intensive care. And today I am going to talk about the rather vast topic of haematology emergencies. Before we get started, I'm not a haematology expert, so I'm sure there is lots of knowledge in the room, and if anybody has any sort of extra things to add, I'd really appreciate it. Just speak up at any point. In terms of what I'm going to cover today, we're going to go through two cases that I thought were kind of interesting and had the potential to catch people out of hours. So we're going to talk a little bit about the pathophysiology associated with them, and the kind of immediate investigation and management things rather than any more long-term management stuff. And I do like a meme, so there may well be one hidden in there somewhere. I hope that's kind of okay with you all on vaguely what you were expecting, but yeah, please just speak up if at any point you want me to go back over things or anything. So the first case is Robert. So imagine yourself as me a couple of years ago. It is about 9 o'clock in the evening, and you were on the night shift on the ITU, and you've been asked to review a 71-year-old patient called Robert, who is on the acute medical receiving unit. Robert is usually pretty fit and well, and he does lots of cycling. He's a long distance cyclist, and he, for the last week, has just been feeling not quite himself. Feels a bit tired, a bit out of sorts, can't really quite put his finger on it. Over the last day, he's been kind of noticing that he's quite short of breath. Initially in the morning, it was when he got up and started moving around, but now it's when he's at rest, and as such that his wife was so worried about him that she brought him into hospital. And by the time you get to see him, he is sat up in bed in the acute medical receiving unit with a bit of an oxygen requirement. So he's got a venturi on. And over the past 4 hours, his oxygen requirement has gone from 2 litres nasal cannula to 60% venturi. This is what his chest x-ray looks like. So you can have some differentials for that. If there were more people around, I'd start saying, let's have a bit of a chat about what the chest x-ray looks like. But it looks a bit wet. He's got a little bit of left-sided pleural effusion. He's got sort of upper lobe diversion, but it could also be infective, couldn't it? And here are his initial bloods. So he's a bit anemic, hemoglobin of 75, and bearing in mind this is somebody who's normally pretty fit and well. His platelets are 24, that's not normal. And what's more worrying is he has a white cell count of 124. It's quite high. When you look at the differentials, it comes back almost entirely neutrophils. Looking at his UNEs, he's got a sodium of 138 and a potassium of 8.5 on his lab UNEs. His urea is 6.9 and his creatinine is 92. And you don't really know what his previous UNEs are like because actually he hasn't had any. He's managed by his GP for, you know, the odd ailment here and there, but he genuinely has no real previous medical history. He had his appendix out as a kid and that was it. So you see a high potassium and you go on your sort of F1, F2 brain of, well, I should probably do a ECG and maybe think about treating that. You do an ECG, which looks like this, which is actually quite reassuring. There's nothing very peaky or horrible about those T waves. He's in sinus rhythm. He's not actually going that fast, but remember I said he was a long distance cyclist, so actually his resting heart rate may well be bradycardic. And again, possibly meets some criteria for left ventricular hypertrophy on the ECG, but it's not awful. And again, he's thin, he's a long distance cyclist. He's probably got some physiological LVH. So that's reassuring. And indeed, when you get your ABG, your potassium is only 4.5. That's odd, isn't it? And the rest of the gas, so he is quite hypoxic. He's only got a PO2 of 8 on 60%. and he's working a bit hard to do that, so he's hyperventilating. His glucose is normal, lactate's slightly high, and also because his white cell count was so high, you can see that the lab have done a peripheral blood smear, which says the majority of cells are large blasts with occasional cytoplasmic granules and pseudopodia. Now, if you're anything like me, you'll go, what the heck is a pseudopodia? We may or may not come back to that later. So, the next question is, what's going on with the potassium? What the heck is going on with Robert? And what would you do as me on the night shift with this hypoxic but otherwise fit man? Anybody got any ideas from the floor? So, about the potassium maybe?
I would do LDH and do they don't do blood flow, but it's like myeloblasts, looking at immature cells that will be released from the bone marrow, because it says blasts anyway.
Yeah, absolutely. Very good point.
Did they have? I would double check with the hematologists to see if the low hemoglobin and the low platelets are related, like a microangiopatic hemolytic anemia.
Yeah.
Because that could basically explain the potassium for high cell turnover, which could release a lot of potassium. Doesn't really make sense with the VBG though. Yeah,
so that's interesting, isn't it? So yeah, if it wasn't for that VBG with the potassium being lower, you'd be like, oh, okay, this kind of all fits. But yeah, no, I agree with you. That's VBG's that in fact ABG is funny, isn't it? That the potassium's normal on the ABG, but not normal on the labs. Any other reasons why that might happen?
Cellulosis is one, but it's in extracellular space. So did they sample it?
So yeah, it's definitely, so it's something to do with sampling. Well, it's kind of to do with measurement really. So it's actually a pseudo hyperkalemia. So people forget about, so when you're thinking of a pseudo hyperkalemia, you always think of the difficult to bleed patient that you've squeezed and squeezed and squeezed, and then unsurprisingly you get a high potassium because you've squished all the cells towards it. But people forget about high platelets or a high white cell count, and this guy's got a crackingly high white cell count. On a lab, potassium can give you an artificially high potassium. So in the case of white cells being high, it's because they are quite fragile cells and break down a lot easier than the rest of your cells. So if they're making up a high proportion of your cells, then by the time it gets to the lab, the potassium in the tube will be high. Whereas the potassium that you do on a blood gas analyzer that's right next to the patient is actually relatively normal because it hasn't had the time for those white cells to fall apart in the tube. So yeah, so it's actually a pseudo hyperkalemia because of that really high white cell count. So what's our differentials then about what's actually wrong with Robert? So we've said, is there a MAHA going on? Any other things that could be causing this?
I was thinking leukemia because the white cells are so high, could cause infiltration into the bone marrow, which could cause platelets slow.
Yeah.
The other thing is because it's bicytopenia with high white cell for leukemia, it could be like a macrophage activation syndrome or HLH associated with a hematological malignancy.
Yeah, absolutely good. So all of those things are on the differential. And in terms of why he's so short of breath?
Anemia, acute anemia can cause increased strain on the heart rate. So
could do. Would it normally cause that chest X-ray though?
Oh yes, and that obviously the pulmonary and bilateral pneumonia.
He could have a pneumonia, couldn't he? So yeah, so on the differential is yeah, he absolutely could have a leukemia. He could have like a pneumonia on top of this new presentation of a leukemia, so that could be causing that, you know, maybe. He could have a degree of heart failure for another reason, but we've seen that his ECG is relatively normal and he hasn't got any history of that. So yeah, what was actually going on with him? So you're right, he's got leukemia, he's got AML, and he has this, which is leukostasis. So when you get a really, really high white cell count, your blood viscosity becomes quite high because white cells are big, sticky things. And as a result, you can get perfusion impairment in your capillary sort of membranes, and places where you're particularly likely to have that be a problem is going to be your lungs, maybe your kidneys and your brain. And in some people, this is the first presentation of a pretty nasty leukemia. It's much more likely when your white cell count is over 100, and it's much more likely when your blasts are high, which his are. In terms of what your actual clinical manifestations of that are, as we've seen in Robert, hypoxic, tachypnic, bit of respiratory failure. You classically get lung and brain, but you can get cardiovascular compromise, you can get sort of renal hit as well, and you can descend further into coagulopathy with that as well. So yeah, something I'd not really heard much of when I first saw Robert, but something that's worth bearing in mind on your differential for somebody in this sort of situation. Your next question then is, how on earth do we manage this crackingly high white cell count? So this is something that is a bit of a hematological emergency, and they need quite intense white cell count reduction like right now, because the more time that they've got sticky blood, the more of their tissues they're going to be, you know, clotting off and becoming hypoxic. So this is the sort of thing where they actually need chemotherapy right this second. And usually they'll start something like hydroxyurea, and then once they know slightly more about what it is exactly they're treating, when they've got a bit more information from genetics or where they've got a bone marrow, then they'll alter their chemotherapy appropriately. We'd also had on our differential, hadn't we, about infection being part of it. So somebody with a really, really high white cell count because of a leukemia can still have a functional neutropenia because the white cells that they're making are rubbish quality and don't have necessarily very good immune function. And so, yeah, high risk for infection. In these patients, you want to try and avoid red cell transfusions if you can. So even though he's anemic, if he's tolerating it, you probably kind of try and avoid it, because in these patients it actually makes the blood viscosity worse, and so can make his hypoxia worse. And then you'd want to be looking for and managing coagulopathy, potentially giving some volume resuscitation if they were hypovolemic, because that's going to make their hematocrit slightly more favouring not clotting everything off. And then also, if they've got a really, really high white cell count and then you're giving them a load of chemotherapy, then you've got to be watching out for tumor lysis syndrome. I don't know whether tumor lysis syndrome is anything you've seen a lot of. You've seen much tumor lysis? No? Okay. So something that's good to remember for exams and also for real life. Tumor lysis syndrome is essentially where you get massive breakdown of a load of cells, usually after you've given somebody some chemotherapy, and the chemotherapy's done its job, breaks down all these nasty cells that are doing bad things, and in the process releases DNA and protein and various bits of your cytosol. And as a result, causes a characteristic pattern on your electrolytes. So you get really high urate, you get high phosphate, and as we know, phosphate and calcium do opposite things to each other. So if you have a high phosphate, you have a low calcium. And you also get hyperkalemia, which can cause you all sorts of problems in terms of dysrhythmias. But the big thing as well is that the urate crystals clog up their kidneys and they get renal failure. Yeah, that's because these things precipitate out. In terms of definition of tumor lysis syndrome, for those people doing exams, there's something called the simplified Cairo definition of tumor lysis syndrome, which has a laboratory definition with some numbers and then a clinical definition. So all of those things plus AKI or arrhythmia or sudden death, which hopefully we wouldn't get involved with because it's a bit late for us, or seizures. Certain malignancies are more likely to do it. I know that's a busy slide. I can send my slides out so that you can see them. But some malignancies can spontaneously do it as well. So you don't have to be on chemotherapy to get tumor lysis syndrome, but it's certainly much more likely once you've had chemotherapy. Patients who are at particularly high risk, the haematologists or the oncologists will give them prevention treatment. So that can be as simple as making sure they're well hydrated and making sure they're not on NSAIDs and things that are already going to knock their kidneys out. And high risk patients will also be given xanthine oxidase inhibitors. And those work because they interact with the pathway of breakdown or metabolism of purines from the tumour cells into uric acid, and so as a result, if you're not making the uric acid, then you can't clog up your kidneys and life is all good. In patients with established tumour lysis syndrome, you might want to actually break down that extra uric acid that they've got, so there's no point giving them allopurinol really, because they've already got lots of the uric acid already on board and they're already in trouble. Which is where you give rasburicase, which is a enzyme that can break down uric acid into allantoin, which you can then get rid of and doesn't clog up your kidneys, which is good. And certainly that's the sort of thing we can get involved with on ITU, is really careful fluid management, giving their rasburicase, careful management of their electrolytes. An important thing with tumour lysis syndrome to remember in the middle of the night is that they'll have like quite a low calcium, and our reflex, or my reflex, is always to treat that, because usually it makes things better, doesn't it? On ITU, it's a, you know, it's an inotrope, it stops people bleeding. It seems like a good idea in somebody with low platelets and low hemoglobin and that kind of thing. But unless these patients are really horribly symptomatic, you kind of just tolerate a low calcium, and that's because they've got loads of phosphate already circulating around. So if you give them calcium, it precipitates out as calcium phosphate crystals, and actually you end up with the same problem that you were having with the uric acid. So you're going to clog up their kidneys. And in these patients, actually filtering them solves a lot of their problems in terms of sorting out their electrolytes, sorting out their fluid balance. And so it's not uncommon to need to filter these people in order to treat them. So that's just a little brief segue into tumour lysis syndrome. So what happened to Robert? Well, I didn't notice that what he had was leukostasis, but fortunately the MedReg did. And so the haematologist met us as we were going up to the intensive care unit to consent him for his chemotherapy, which he started that night. I went from a very sort of well-looking man to a very unwell-looking man over the course of the night, despite his chemotherapy. He became really agitated and actually disproportionate to the hypoxia he had. He was not hypoxic enough to necessarily cause that agitation, which makes me think he probably had some cerebral involvement from his leukostasis. I pulled out all of his lines and ended up needing some iron ketamine in order to get a tube down him at 3 o'clock in the morning, which was not a fun time for any of us. He descended quite rapidly into multi-organ failure and unfortunately died the next day despite fairly aggressive treatment of all of those things. And bigger picture with him, actually, so he had AML, and although lots of hematological malignancies, our treatments are getting way, way, way better, and we're admitting people that we never would have admitted to ITU before, because sometimes we can make their malignancies just melt away. For AML, as you get older, your prognosis gets quite bad. So he was kind of a little bit doomed, unfortunately, and it was very distressing for everybody. But it's an interesting case, and it's something that's rare, but I think it's worth knowing about, because if you do see it, it's something that you have potential to make a big impact on. Any questions on that case? Okay, you've had your 7 seconds. That's how long it takes an adult to make a question. We're going to move on. So we're going to move on to Kate. Kate is 25, and she's an avid rock climber. She's got some well-controlled asthma. And you are called to the acute medical unit in the middle of the afternoon to see her because she is a bit drowsy and not quite right. And the story goes, she has had a really awful headache for the last 5 days. She went to a GP yesterday who couldn't find anything particularly concerning about this headache and sent her home. The headache got worse. It got so bad that she came to A&E, and while she was waiting in Miners, she proceeded to have a seizure. and it all got very dramatic very quickly. So, what would you do now? Any thoughts in the room? So, somebody fit and well, headache, has a seizure. What sort of things are you thinking?
We'll do blood count with blood flow. We're thinking of TTT.
Is that what you could go straight for if you weren't in a haematology lecture?
I mean, she's young. She's young. She had headaches, seizures.
You might CT head. You might do an LP.
I'd probably just rule out the massive subarach first. But yeah, yeah, I agree with you. Yes, we're in a haematology lecture. It does start to sound a bit like TTP. Thank you very much for ruining it. Geez. Okay.
She's also a medic.
Say that again.
I was just saying she's also medical, so full disclosure.
Full disclosure, we've got a medic in the room. Fair enough. Okay. So yeah, somebody who's had a seizure, simple things, awful headache, seizure. So you want to be thinking about a bleed in her head. I know she's young, she's previously fit, but she could have some congenital reason why she could have a sudden subarach. Meningitis, maybe. Not classical, but possible. And then things as well, like you want to make sure she's not hypoglycemic and something stupid like that as to why she's had a fit. So yeah, of course, a CT brain was. I mean, we're in a haematology lecture, so of course a CT brain was fine. ABG, not that exciting given she's just had a seizure. She's got raised dynamic metabolic acidosis, but only really mild. Mildly raised lactate, glucose, methemoglobin, carboxyhemoglobin all normal, ketones normal, and on her full blood count, hemoglobin is really quite low, 45. Platelets are even lower at 14. White cell count of 12. And she's got an AKI. Her clotting screen is actually pretty much normal, right, mildly raised INR, but we're not in sort of DIC kind of territory as far as we can tell from our initial cursory looks. So, medic in the room. So you wanted a blood film. What else did you want?
No, I just if you did, because usually when you go to A&E with something like this, apart from CT head, they do a full blood count. And hematology, usually if there's low hemoglobin or platelets, because you're thinking of microangiopathic hemolytic anemia, they usually tend to do a blood film anyway. So it would all be done even before you could even ask for it.
Yeah, absolutely, which is good. And yeah, you absolutely do get blood film. So and you get some other tests as well. So you'd asked for a haptoglobin, which was less than 30. So what's haptoglobin? What's that for the non-medics? Oh, I thought we had an answer. Sorry. Any thoughts as to what haptoglobin is? No. Anybody at the other end of town? Okay, so haptoglobin is something that your liver makes, and it kind of mops up free hemoglobin. So if you've got lots of free hemoglobin circulating, then your haptoglobin level will be low because it's bound to all of the free hemoglobin that's going around. Because free hemoglobin is actually pretty toxic. So somebody with a low haptoglobin, you're thinking, well, there's lots of free hemoglobin going on, which means hemolysis, right? Yeah. And similarly, LDH, so lactate dehydrogenase, being high means you've got some cell breakdown, which is non-specific, but in the context of hemolysis, that fits, doesn't it? Is that you've got loads of red cells being broken down. And you've got a peripheral blood smear, which says high reticulocyte count at 19% and multiple schistocytes. And in the middle of the screen over there, you can see what schistocytes look like. So schistocytes are essentially red cells that have been mechanically torn apart, ripped apart in the bloodstream. So you get these sort of bits of red cells floating around the blood. And a direct antiglobulin test was negative. So what that essentially says is there's no autoimmune reason why the red cells are being broken down. They've not got an autoimmune hemolytic anemia. So hemolytic anemia plus schistocytes on a blood smear is microangiopathic hemolytic anemia, or MAHA, which is equivalent to non-immune intravascular hemolysis. And we get that broadly for two reasons, although we're then going to establish that we get it for 1,000,001 reasons. But broadly, we get it for two reasons. One thing is that there's something physically breaking down the red cells in the circulation. We're at Glenfield, people have prosthetic valves, people have mechanical devices. So actually, yeah, you can get physical fragmentation of your red cells, and that could be causing why you've got this situation going on. Or in your more general medical population without a reason why their red cells are being broken up, there's this group of conditions called thrombotic microangiopathies, which are conditions that cause development of little clots in your microvasculature. And because everything gets really, really clotted and really, really tight all over the body, you get turbulent flow in systems that were previously laminar, and the cells get ripped apart by this sort of high turbulent flow in lots of your microvasculature. There are 3 components to thrombotic microangiopathy. So we've said this microangiopathic hemolytic anemia is one component to it. You also have thrombocytopenia, and also you have a degree of end organ damage, and that can be really quite variable. And then you've got to think, well, if I've got a thrombotic microangiopathy, what sort of thrombotic microangiopathy is it? Now, this is not a very anaesthetic sort of question, is it? Because normally we're bothered about the physiology rather than the actual diagnosis, and we're quite happy provided the numbers are okay. And unfortunately, there are lots of different sorts of thrombotic microangiopathy. So you're saying, well, why, Laurie, are you torturing me with this? I do not care about whether it's TTP or HUS or secondary to malignant hypertension. And I won't read the rest of them because you can read that for yourselves. Why are you doing this to me, Laurie? I don't know why you're torturing me. And so the reason why, here are some tests, by the way, you can do it, is because it actually does matter in the immediacy, because the different types of thrombotic microangiopathy have different treatments, and some of them actually need to be started right hecking now. And so it is worth just thinking for a second about this. Oh, the phone's ringing. I don't know what that means. Thank you. So yeah, I don't expect you to read all of those things, but so if you've got TTP, that requires urgent plasma exchange and some steroids. If you've got atypical HUS, it requires a monoclonal antibody to your complement called eculizumab. I hate saying those words. Whereas actually, if it's sugar toxin-related hemolytic uremic syndrome, you just need supportive therapy. But unfortunately, a lot of these tests that you've got, so like your ADAM-TS13 level, which is really helpful in TTP, you don't get that for several days, and you should have started the treatment by now, because otherwise they may well have not survived the experience. So unfortunately, it does require you to actually start the treatment before you know what the diagnosis is for sure, and it's a probabilities thing. There are some things that you can use to help you. Again, this slide is wordy and difficult to read, but you can have my slides afterwards. And there is a link at the end to where all of these came from, so I can show you that. But different types have slightly different clinical pictures. There's also something called the plasmic score, which actually, if you have a high plasmic score, that quite strongly correlates with a high risk of TTP. And so if you've got a high plasmic score, you can be fairly confident that you can start treatment for TTP if it's fitting otherwise. And here is another slide which just elucidates the sort of different pathways that you might go down. But the important thing being that TTP is the thing that needs plasma exchange fairly quickly in order to halt the disease process. So if you have got somebody who you've got thrombocytopenia and you've got microangiopathic hemolytic anemia, which, by the way, you need to go looking for and check that, actually look at their blood film and that kind of thing to make sure that they have or haven't got it, then actually you're probably best off starting to treat as if it's TTP, and then you can always adjust your treatment when you get your results back later. What happened to Kate? Well, she had some plasma exchange later that day, and by the next morning it was like pretty magic in that she'd been kind of drowsy and off it, not quite right. And the next day she was sat up on her phone, much better. Her ADAM-TS13 activity level came back as really low. and she was discharged home on some steroids. So just for those of you who need some reminding as to what TTP is, all of us hopefully have this enzyme in our bloodstreams called ADAMTS13, which cleaves von Willebrand's factor to make it into little blobs that don't clog things up. Right? If you don't have ADAMTS13, then von Willebrand's factor stays as these massive multimers, and those then clog up all of your little vessels and give you schistocytes, because you've got high, as I've said before, high turbulent flow, high pressure through small vasculature everywhere. So the red cells just get sheared and you get hemolytic anemia, and you get microthrombi, which give you tissue ischemia. And treatment of that is plasma exchange. And crucially, these patients don't tend to need, despite the fact her platelets are 14, she doesn't need platelets to put in the VAS cath, provided you're not leaving somebody who's really inexperienced to do it, obviously. But somebody experienced putting in a VAS cath should be able to do it, because actually the evidence is they don't tend to bleed, although of course take advice from your haematologist at the time. Any patient who's had plasma exchange, you then want to give some sort of immunosuppressive chaser, and in the case of TTP, that's steroids usually. You want to control their hypertension, because the higher their blood pressure is, the more of this shearing of their red cells they're going to get. So there isn't, as far as I'm aware, a set cutoff, but ideally you want to probably keep people's blood pressure sort of under 140-ish systolic or something. That's what I've read anyway. You don't want to give platelets, you don't want to give red cells, because they tend to drive the process that you've got going on underneath. So unless somebody's actively bleeding or wildly symptomatic, you kind of don't want to. And then these patients are also high risk for clots, so VTE prophylaxis is really, really important. And that's pretty much it. So there's 2 cases of patients that have interesting things that can happen out of hours that you kind of need to interact with and not just wait to the morning, because it will make a big difference. So we talked about leukostasis and how it can be a new presentation of a leukemia that needs urgent chemotherapy overnight. We talked about tumor lysis syndrome, about how it can come on spontaneously but more often after chemotherapy, and it can cause crushing renal failure and electrolyte imbalances that need treatment overnight. And then we talked a bit about MAHA and TTP, and again how after consulting with your haematologist, you probably need to get them to the unit, get a VAS cath in, and get plasma exchange going ASAP. And that's pretty much all I wanted to talk about. If you're interested, those QR codes take you to some useful resources on those things. If I move that down, you can actually get to it. Does anybody have any questions before I stop talking and let Lucy do her journal club?
Hi, Laurie.
Hello.
Thanks very much. That was a really good talk. I just wanted to say I've put a link in the chat. There's a national referral service for atypical HUS, and they've got some useful info about how you diagnose and get your eculizumab going and everything. And there's some good info about differentiating it from TTP and Shigella linked HUS and everything like you mentioned. But it's useful in case anyone comes across one.
Well, thank you.
Hi everyone, I'm Lucy, one of the new regs at Glenfield. So I've been given the lovely paper which is entitled Non-Invasive Ventilation in Patients with Acute Hypoxemic Respiratory Failure, a Systematic Review. So we'll just go through it. I like to keep things fairly simple, and I'm not an IOCM trainee, so we'll take what we can from this. I can get it to work. Here we go. So this was, this is a systematic review and meta-analysis of randomised controlled trials that was done by some Thai doctors. And essentially it compares non-invasive ventilation, so mainly BiPAP, to conventional oxygen therapy, and or high flow nasal cannulae in acute hypoxemic respiratory failure, or essentially kind of type 1 respiratory failure. The primary outcome was tracheal intubation, so rate of tracheal intubation, and the secondary outcomes were ICU mortality and overall hospital mortality. And this paper was published online this year in the Nature Scientific Reports. Obviously Nature, very big name, but this is their kind of online open access journal. So just to quickly define acute hypoxic respiratory failure, so PF ratio of less than 300 millimeters of mercury, requiring significant oxygen supplementation and accompanied by clinical signs of respiratory distress. And the paper does outline the main causative pathologies for each of the included studies, which mainly included community-acquired pneumonia, acute lung injury for various reasons, cardiogenic pulmonary edema, and then I don't know if there are quite a few transplant centres involved, because another big cause was kind of post-transplant ARDS, pulmonary edema, things like that. So they, a group of them carried out a review according to this protocol, and they searched all the major research databases, and these were their keywords that they were looking for. So variations of NIV, CPAP, positive pressure ventilation, and then acute lung injury, ARDS, etc. They all the studies that they included ranged from January 1995 to August 19, which is fairly relevant, which we'll cover in a minute. So they covered studies which involved adults, sorry, that should be over 18 years, with hypoxic respiratory failure. The trials that compared NIV with conventional oxygen therapy or high flow nasal cannulae. And then those that had outcomes that included one or more of intubation rates, ITU and hospital mortality. And they only included those that were in the English language. So they, after filtering everything out, they used 17 studies, so about 1,700 patients. And 2 authors did the review independently and then compared each other's findings and published it. So from those search criteria that I showed you, there were over 4,000 articles, which they then screened 2,700 and included 17. So what did they find? So out of all of these studies, nearly all of them included intubation rates, and they found that intubation rate was lower in the NIV group compared to the conventional oxygen therapy groups, and that had a p-value of 0.005. And the secondary outcomes found that there was no difference in ITU or hospital mortality that were statistically significant. Although if you look at the risk ratios, and actually the hospital mortality had a p-value of 0.05, so that's nearing significance potentially. And then they did some subgroup analyses, and they found only two out of the 17 studies actually compared NIV to high flow nasal cannulae. The rest were just to BiPAP. But from those 2, they found that high flow nasal cannulae was kind of about as effective at reducing intubation rate as NIV. And they also found that helmet NIV was a lot more effective and reduced intubation rates compared to full face mask NIV. So essentially, NIV helps people and reduces intubation rates in these studies, but it doesn't reduce mortality. And high flow nasal cannulae is better than face mask oxygen, and helmet NIV is more effective than face mask NIV. However, we'll talk about the paper. So I think that the protocol for the review was fairly robust, and they used standardized. Oh, can you still hear me?
Yep, we can still hear you.
Yeah.
It's just asking me to join. I thought I was joined. Hang on. Can you still see the slide?
Yeah.
Okay. They only looked at randomised control trials, so kind of decent level evidence. But I thought that they included studies from nearly 30 years ago, and things have changed quite a bit since then. Obviously, I wasn't around, but I don't know how effective kind of NIV and ventilators have become since then. So thought that was a potential change there. They stopped in August 19 when just before COVID hit. So obviously there's been a huge amount of research and experience over the last few years in a very specific hypoxic respiratory failure. Sorry. Only 2 out of 17 studies compared high flow nasal oxygen. So I'm not sure really what conclusions they can properly draw from that. And also they included a very wide variety of pathologies, which, I wonder if you broke that down further, whether you would see benefits in the different strategies. But anyway. And in the paper themselves, they say that there were, a huge variety of baseline characteristics covering that many randomized control trials that were all kind of very different protocols with different aims and things. So, and they also had different cut-offs for hypoxemia and stuff. So will this change our practice? So I kind of feel that potentially by the time this was published, it was kind of potentially already slightly out of date, in that we use very old trials, quite a lot of old trials, and we now use high flow nasal cannulae. Certainly in my recent experience, we use high flow nasal cannulae a lot more, probably like more than we use NIV. So I think we probably already know a lot more than this paper tells us. But I'm interested to know if this will change anyone else's lives. And that's it. Laurie, do you have any thoughts?
Anything from the room? I don't know whether it's necessarily going to change my practice personally, but maybe it should. I don't know.
No, I don't think so. Any other comments?
You should have added more forest plots when you're comparing RCTs.
Sorry?
You should have added a little bit of forest plot when you're comparing RCTs.
Yeah, so I can send the paper. There are some. I haven't put them on the slide.
And how many RCTs were very old? More than 10 years old. Out of the 17 that you said.
Yeah, I can't exactly remember. Let me have a look. So 14, 13 of the 17. Yeah.
So this becomes irrelevant because more than 10 years ago, things were very different, as you rightly pointed.
Yeah. Yeah. So they range from 1995, 99, 2000, 2002, etc. So yeah, I agree.
Thank you.